Okay. Okay. So let's see. Now, in a transdural view, we are looking at the gallbladder. A lot of sludge, debris. He's already got a metal stent in the bile duct, right? So, yeah. Okay. All right. So we have a patient getting liver biopsy with EUS. Okay. So first thing for us to do is now come at the G junction. So let's just say here, right? So this is about 42 centimeters. So G junction, you turn, push the scope down a little bit, and then as you do counterclockwise, you're going to look at the spleen. You do clockwise, you're looking at the liver. Okay, and you push the scope down. So this hole, you're looking at the entire liver here, and come back. So the left lobe of liver is sort of anterior to the stomach, right? So when you're here, to look at the left lobe of liver, you're going to be right here. So this is more clockwise. A clockwise movement will get you anterior, looking up towards the, skin. So the left lobe of liver is between stomach and the skin. So that's what we are looking at right there, right? And then you do counterclockwise, and you're going to look at spleen. You do clockwise, you see the liver in its entirety. And in this case, I mean, the liver looks, it's a little heterogeneous. I mean, there is, I would imagine that there is cirrhosis in this patient now, which I think has been suspected, right? Yeah, so what we, right. So let's do elastography and shear wave quantification. And here, so as we do this, so you want this box about 2-3 centimeters from the capsule, and it has to be in an avascular area, and there has to be no blood vessel in it. So when you're doing this, right? So here we go. So we keep it stable, and then time with the respiration before there's movement. Okay. So now you look at the screen. So the E is 53 kPa, and confidence interval is 100%. So it's a good quality reading. And 53 kPa would imply, obviously, pretty hard cirrhotic liver. So ideally, you want to take 10 readings. So this is a good reading. Okay. Go again. Okay, 35. So there's a bit of variability here. This one's 35, that one's 53. Anyway, they're all in the cirrhotic range, so it's high. Okay, cool. So let's plan for biopsy now. When you're doing biopsy, obviously you want to find an avascular area, and this looks like a pretty good area to get in. And it's the left lobe of liver right there. Near the needle. Yeah, so 19 gauge, I think we'd had a discussion the last time, and I think most of us across the country use a 19 gauge. And I'm using the Boston Acquire. Let's see. So you're doing... Yeah, so that's the idea. The idea of heparin flush is to avoid a blood clot, which will impede your ability to get a good quality tissue. So heparinization is generally recommended. That's worked better in terms of tissue sample. Otherwise, the clot's going to obstruct, and then you won't get a good quality sample. So that's one. So flush it with heparin. Have a little bit here. You're doing about 20 cc of negative suction. I know people have done a little less as well. We've always done 20 cc, which works for us. And let's see. Again, get a Doppler. Make sure there's nothing in the wall, because I've had one patient who bled from the wall. It wasn't obviously pleasant experience. So we want to avoid anything in the wall and the capsule, right? So the bleeding concern is by and large the wall, the capsule of the liver, and anything intrahepatic obviously as well, but mainly capsule is the area. Now this is where I'm going to go potentially. So do a Doppler. Looks pretty good there, right? Yeah, okay. pull back a little bit, and I'm going to go here, and yeah, okay, so push out a little bit. So now we are there. Let's do a Doppler again. Looks fine, right? Okay. Now at this point, you want to see how much depth of insertion you can do safely with an avascular sort of, oh shit, okay, let me try it again. So this is where the needle is coming from, like this, right? Yeah. So you want to measure from here and get that axis. Okay, so we go, say this way, we're going to get easily till here without hitting any vessels. About a 4.5 centimeter runway, which is pretty good, right? Okay. To time it with the respiration as well and avoid any vessels. So I'm going to use big wheel, suction, and okay, ready? That left me a little bit. Okay. Yeah. All right. I'm going to push it up. Yep. Okay. Stop. Now suction on. So I do 4 actuations. People have done less with good results as well. So I'm going to pull back. And I think it's just at the far edge. So it's reduced my ability to, push the needle in much further out. But okay, I'm going to pull back a little bit. Maybe do a little rotation of the scope. Go again. So that's actuation number 2, number 3, and I'm going to rotate the scope more, pull up a little more, and number 4, and there's a little bit of blood. Okay, come back, and at this point we can stop the suction, get the Doppler, see what are we dealing with in terms of any tract bleeding, because he's a cirrhotic guy, so there will be a higher risk of tract bleeding. I'm going to keep the needle there because I can see flow in the tract, right? Yeah. So I think we just keep the needle in for a little bit. Question is whether you want to use gel foam and sacrifice this. Yeah, I'm not a big fan of obviously sacrificing in the tissue now that we have gotten it. But at the same time, you don't want any risk of bleeding as well. So there is a little bit of flow there in the tract, right? So hopefully just give it a little more time, let it clot off. So I'm going to wait on it. Yeah. So cirrhotics, despite their reasonable platelet counts, will still have coagulopathy sometimes. I mean, rotem is there, people do it, but there have been like a lot of people who don't believe in rotem as well. So I think it's a little all over the place. Some studies now definitely have shown TEG rotem to work better. You see now the flow is reduced in that, right? You see? It's definitely gone down, right? So what I would do is just keep it there. The idea is that the needle hopefully is serving as a tamponade, and it's preventing, the blood to extravasate. So we'll just wait, give it some time, 13:54, yeah. I'm going to give it another 30 seconds. Just stay there, and then we do a Doppler. Okay. Yeah, there was a little bit of bleeding in the tract, yes. And I think where I intended the needle to go, it went a little bit on the side, which can happen. I think the liver did get pushed off when I initially punctured, is what you could see. So let's see now. Yeah, see, much better, right? I mean, there's hardly any flow there, right? Yeah, good. So that's good. That's happy. There's a little bit of flow near the tip, but I'm just going to stay here, give it a few seconds. Yeah, okay. Now that's reassuring now. So you wait. You probably spend at least a couple of minutes now, yeah, waiting on it. I think it should be okay. We pull it out. Okay, good. Done. Okay. Okay, so immediately of the block, you want to make sure there's nothing coming out. So let's see. Visualize this area in its entirety over here, and it looks fine, right? So far, it looks okay. So that's reassuring because there would be something, you'll be able to see that extravasating going outside the liver and then may cause a bleeding, but so far it looks okay. All right. Let me know when the sample is there. All right. So that's one. The other thing when you're doing now, which we have now started doing, is that splenic stiffness, which I think I mentioned that to you, which is a little slightly easier than measuring liver shear wave. Now here in this case, you can see this guy is chronic pancreatitis, PD, body, stone, going down clockwise. This is the tail, and so go all the way here and counterclockwise. This is your spleen. Yep. So, yeah, okay, there you go. So whenever you're doing elastography, you don't want much strain on the wall. So if this wall is compressing the organ, it's going to give falsely high values. So that's the other thing. Now I'm going to not use a big wheel too much. A little bit is okay, but not too much. Okay. And then we do elastography. Let's see this one. Yeah, okay. Same thing. You don't want to avoid any vessels from the capsule. All right, let's see. So that's not too high, but confidence interval is 5%. So that's the problem. So can't go with this reading. %55%. Okay, not bad. But now something more in line with what you would expect in high kPa values in a cirrhotic patient. See a different area. 78, right? So there you go. So it's all 50 and 60 range. It's highly stiff liver from the cirrhosis. Yeah, lovely. Yeah, good. Yeah, we've got good chunks. Show me once again. Yeah. Okay. So see, you can look at it under the light. Yeah. Okay, cool. Yeah. And then we go back and assess our liver again and make sure there's no blood. By and large, I mean, if it looks fine now, then we can be rest assured it'll be okay later. Probably, but we were doing, but then we've had a bleeder before, so we tend to keep the patient for an extra day now, ideally. Come.